morning, depending on what time zone you happen to live in. I'm Norm Thurston. I'm happy to welcome you to our second Igniter session for NATO's 37th Annual Conference, Putting Healthcare Data to Work. Today's Igniter session is titled Harnessing New Data Transparency Rules to Spur Change. And our speakers are Avital Havusha from New York Health Foundation and Kevin McAvey from Manatt, Phillips and Phillips LLP in New York. You can read their bios by scrolling down and clicking on their names, but we're going to just jump into it. So Avital, why don't you go ahead and give us an introduction to today's topic?
Great. Thanks everyone for joining us today. We're excited to share a bit more with you about some work that we did at the New York Health Foundation in partnership with Manatt to really focus on some of the new price transparency rules that went into effect at the federal level over the course of the past year or two. We dug into one of those transparency rules, which was around data for prices at the hospital level, but there are some subsequent policies that also went into effect around health plans that had a similar flavor. And we want to share with you a little bit more about what those results showed, how they align with our mission here at the foundation, and also kind of the public-private partnership we built with Manatt. So we'll jump into some slides and we'll go from there. So first, just a brief introduction to the New York Health Foundation. We are a private independent foundation that seeks to improve the health of all New Yorkers with a focus on the most vulnerable populations. But in addition to being a grant maker, we also do a lot of work to inform healthcare policy, to try to spread best practices across the system, and serving as a convener across the state. And one of our key priority area programs is what we call consumer empowerment. And one of the anchors of that program has been a focus on supporting projects and policies that increase transparency of data, whether that's data about prices, data about quality, data about patient experience. And so, of course, and I'll talk a little bit more about the policies that went into effect this year, one of the key pieces has been some of the groundbreaking policy that's passed over the past few years. So I'm going to turn it to Kevin to introduce Manatt, and then I'll go back to tell you a little bit more about the work that we did.
Yeah, thank you so much, Avital. My name is Kevin McAvey. I'm a director at Manatt Health Strategies. I was joined on this project by Amy Zahn, a manager with Manatt Health, and Joel Ario, our managing director here. Manatt and our practice at Manatt tends to support states, foundations, payers, providers across the country to understand how they can use data to advance their health policy and program goals. And it was an absolute pleasure to support the New York Health Foundation through this work. So Avital, do you want to describe a little bit more about how we actually work together?
Sure, absolutely. So, one of the key vehicles the foundation often uses, especially at these moments when there's maybe a new policy that's gone into place or a new regulation that's gone into place, is we really want to see what's happening on the ground. And so we'll often forge a partnership with an organization like Manatt to really do that in-depth analysis so that we can make sure that policy is then implemented soundly. So that was really the starting point for this particular project. So why don't I give us a little bit more of the state of play around this hospital transparency rule? So that's just on the next slide. Great. So in terms of price transparency, the state of play, there's a lot to talk about here. I'm going to try to distill it down a bit so that we have time for conversation. But there were a whole range of policies and regulations that have gone into effect since around 2020. One of which was a rule around price transparency, both for hospitals and for health plans. The hospital final rule went into effect in January 2021. And subsequently, a rule for health plans went into effect in 2022. We're going to talk about the 2021 hospital rule today, but there's lots more to talk about if we were to expand out, and happy to do that in the discussion. But the basic point around this hospital transparency rule that went into effect and then was promulgated by the Centers for Medicare and Medicaid Services was really that it requires hospitals to publish 5 categories of standard charges for all of their services, and they have to be published on a publicly available website in 2 ways. One is a machine readable file. We'll talk a little bit more about what that is. And the second is a consumer-friendly display of 300 what CMS calls shoppable services. So things that you can really schedule in advance and shop for, whether that's a joint replacement or a service like physical therapy. And so we wanted to dig into, in that 2021 period, how well were hospitals across the country, but specifically for us at the New York Health Foundation in New York, implementing this policy. And it was against a rather kind of media backdrop that actually there was a lot of attention to this issue. You might have all seen various newspaper articles, other national studies that came out that really did document some pretty wide scale, either non-compliance or kind of uneven implementation. So that was the backdrop that was at play. But we took a particular perspective around our analysis that was more specific to some of the implementation. But I think, Kevin, maybe you can talk us through just a little bit about the provisions of the policy.
Yeah, absolutely. So Avital mentioned the 5 different charges, or the 5 different data points that are released. Gross charges, discounted cash prices, payer-specific negotiated charges, which really made this in 2001 and previous legislation or legislation prior to that a really kind of novel, groundbreaking sea change in transparency, revealing those prices that have long been protected. It also included de-identified minimum negotiated rates and maximum negotiated rates. And as Avital mentioned, think about the data release requirements in 2 different buckets. One were like consumer-friendly tools, like for shoppable services, the top 300, and that hospitals could either satisfy that requirement by having a web display or file of the standard charges, or by developing a consumer-friendly internet-based price estimator tool. And then for kind of data nerds and wonks out there, including myself, like they also had a provision for machine-readable files. So these are files that can be put out into the market and imported pretty easily into programs for third-party applications to aggregate and analyze and provide useful information to different audiences. So those were the requirements. But Avital, do you want to actually talk about like how we went about assessing compliance or adherence to those rules?
Yeah, hey, that's a great idea. So Kevin, let's right now let's just take a kind of dive deep into what it was that you wanted to study and what did you want to figure out? Kind of like what's the whole point of where we're going? So is that on I think we have a slide for that. Maybe Charles, could you go to the next slide and we'll talk about this?
Great, thanks. So yeah, that's exactly, Norm. So then what did we do? We dug into this by creating our own analysis framework. And we really set out to understand how hospitals were implementing the rule. We as an organization and Manatt, we weren't assessing compliance. We really took a more sampling methodology. And our goal was really to look at this as a implementation, as an incremental process. So we wanted at the outset to think about like how were hospitals meeting the spirit of the law with respect to some of those requirements, and to be able to maybe start to parse out some ways that they were doing it really well, if there were examples of those, so that there might be opportunities to share them across other hospitals. And so what we did is we kind of used a levels of implementation framework that you can see here on the slide: not implemented, partially implemented, or implemented. And we had a whole methodology to assess that in terms of how a particular hospital might meet those implementation levels. And we looked at things for each of those areas. So for shoppable services, we had a certain set of criteria around assessing how well the consumer could obtain information from the tool that was available on the website. For machine readable files, the other provision, we took a look at how accessible those files were. We didn't assess everything that was in them, but we looked at the kind of the availability of those files, and then we put them into these categories around implementation. And that was our overarching approach to the assessment process.
Yeah,
so
that's very
implementation.
I think that's a very interesting way of setting this up. So across these 32 hospitals, you're evaluating them and giving them points for their progress in various areas. So let's take a look at what you found. Let's see.
Yeah.
I'm curious as to how this went. Do we have a slide on that? Yes, we do. Great. All right, let's do this.
Great, Kevin. I think you'll kick us off.
Yeah, sure. So from like a spirit of the law perspective, I think when we did this sampling earlier this year, we saw increasing compliance by New York sampled hospitals. We saw greater or increasing implementation of the rules from New York hospitals, greater progress towards for implementation of the shoppable services requirements than the machine readable requirements, but some interesting differences between them. So for the machine readable file requirement, approximately 19% of hospitals that were sampled had not implemented this requirement. 69% had partially implemented it, and 12% had implemented the requirements by providing price information in all 5 categories of charges. So 12% fully implemented, not
only four out of the 32 are where they should be. Is that kind of what I'm understanding here?
So of those, when you actually kind of peeled back the onion of what the legislation required, point by point, had fully implemented all of those requirements. And that this is not new news. I think we actually, as of like August 10th, an article came out that hospitals nationally, 16% were only had fully implemented the federal price transparency rule. So like full implementation remains low. Keep in mind, this is a hard requirement for lots of hospitals and does require significant kind of culture, implementation, operational change to implement. We see some progress, but probably not as much as many would like.
Okay, so for those that are kind of effective, did you notice anything that was an effective approach that you could maybe share with the other hospitals to make the data more consumer friendly?
Yeah, absolutely. So in the machine readable file provision, we saw some characteristics from hospitals that fully implemented that were really promising. Some were really clearly labeled, well formatted, intuitively organized with columns and rows, and allowed the user to conduct a digital search of the document. They also included data that appeared to be generally comprehensive and complete from what we could tell from our high-level analysis of these macro files. On the shoppable service side, always providing clear estimates of consumer expected out-of-pocket costs for the specified service and providing an intuitive layout. Like if I were going on the website and not knowing anything about healthcare, like could I navigate to the information I needed at that point in time pretty easily? So there were some best practices that emerged from hospitals' implementation of the provisions.
Oh, good. That's very helpful. So from a kind of learning perspective, how do you see this hospital data transparency effort broadly fitting into other pushes for informed consumers and value, et cetera? Where are we headed with all of this? And do we have any hope that this is actually going to work?
Yeah, I think that's a great question. And some of that's highlighted a bit on the next slide, and maybe we can get into some of those themes in the last few minutes. But like that big question, the first bucket there is what is the real benefit to potentially consumers? And I think for us at the foundation, in many ways, like we've said a few times throughout the presentation, it might be somewhat of a groundbreaking and kind of sea change moment in terms of transparency because of these sweeping federal laws. And that means that, there's a potential for consumers to have more data in their hands, but we also recognize that these rules are not the panacea for consumer empowerment. They're necessary, but they're not sufficient. And we really have a lot of work to do to make the data more usable for consumers themselves. And the data right now, as it's currently constructed, when you download it from a website, especially in machine readable file, was not designed for that, even for the most savvy healthcare provider. Some of the work in the shoppable services tools, we're starting to see some potential, but we also see a lot of work being done by third-party applications and others to affect data accessibility and distilling that data and digesting it for consumers. So there's probably some hope there that some of that will happen and that there'll be some comparability across hospitals, for example, because somebody will take the data and digest it for consumers and others. And then, I think there's just some other possibilities around kind of competition and, influencing one hospital doing something really well, to Kevin's point about good examples and maybe adopting a best practice from another hospital. But there's some real challenges that remain that we can talk about around, what are some of the gaps to assessing implementation moving forward.
Okay, so I think it's about time for us to take a look at some questions from our audience. But before that, we do that, I want to have one last question, just a real short answer. Third-party aggregators, is it happening or is it going to happen?
Great question. Kevin, do you want to jump in maybe?
Yeah, sure. So I think it's happening, but it's not happening in the way that we all initially might, if we were redesigning the world, might want it to happen. I think that there are a number of entities out there, like Turquoise is one that immediately comes to mind, that are doing some great work in like scraping this data and trying to make it useful for others. The problem is, or not the problem, or like the result of that is you have to put a lot of effort into making this data usable. And for many organizations, you have to make back that effort you're putting in to actually pay for the endeavor. And so you often have to sell this data to private vendors, which kind of defeats the public purpose that these the spirit of these price transparency requirements was trying to advance. So I think that there is this missing gap of like, how can we get this data in the hands of entities that can use it to ultimately benefit consumers, and that's the missing link that many in the field are currently working on.
Okay, well, what we're going to do now, we're going to do some interactive audience Q&A, and we're going to direct those towards Avital. So we're going to have Avital be on screen, and then Charles is going to read those questions to her. So let's go ahead and give Avital the floor. And Charles, go ahead with those questions whenever.
Hi, Avital.
Hi.
Thanks for presenting. So I'm noticing that we have some questions and comments here in the chat.
Yeah.
One of them is more of a comment about the experience, and it sounds like this might be a common experience. Richard saying that he found a lot of different file formats. I'm wondering if that's something that you would like to speak to.
Absolutely. You know, I think that that's for sure what we found in our analysis as well. That was some of the starting point for us when we thought about kind of identifying what we would consider these effective examples of implementation, and why we thought things like that didn't necessarily rise to the occasion of a best practice per se, because the file should be, at least anyone should be able to actually download the file. So we thought that was effective implementation. It wasn't necessarily best practice. But we saw a similar thing across the sites that we assessed. There was a real variation in those files, how easy they were to download, how easy, if they had searchable features in them. And I think that's just speaks to one of the overarching challenges around this rule, is that there might be transparency, there's a file, but then once you download them, how comparable they are. Can you compare the data? Can you even compare the files in terms of, you know, what the rows and columns are? And so it speaks to, I think, an overarching challenge around the data and how it's presented.
Yeah, that variation in structure and format. We have another question here from Mel. He says he's wondering where we might find this type of information for another state, such as Virginia.
Yeah, great question, Mel. So there's a few national studies out there that did some sampling. There was one from which we can probably share around after. There was one from JAMA earlier in the summer, and then there's a most recent report that came out that was covered in Axios and was from the patientrightsadvocate.org group that did a more sampling across states, and I think Virginia was included. And so we can definitely get some of those reports out. There might be that we're not aware of other groups kind of like us in certain states who might have dug in on their own. We know of certain groups that almost like took it upon themselves to start digging through some of the data. So there might be some that wasn't published in the same way that's out there that we don't know about, but we can share those two resources.
Okay, that'd be great. And just so everybody knows, there are some links here too below the video that you're seeing right now that Avital shared with us ahead of this meeting that go to the report, as well as some reporting on this issue. So we can put that link in there if it doesn't end up somewhere else sooner, essentially. In the chat.
Fabulous. That one of the reports I mentioned is in that link.
Oh, okay, perfect. I mentioned that. Thank you. Looks like probably our last question here is from John Daly, and it gets at one that I'm also interested in, which is, and we talked about briefly, which is kind of what are the states doing as far as compliance, and then what is the penalty for non-compliance, and who would enforce that, I guess?
Yeah, absolutely. So the compliance piece has been, so of course, as I mentioned in the beginning of the presentation, we didn't seek out, we're not a compliance body, and Manatt's not a compliance body. So we sought to kind of take a more implementation frame to our work. But there is, of course, a compliance component to this as well. And CMS at the federal level, the Centers for Medicaid and Medicare Services and Health, and they're really responsible for compliance. There was some pushback at the beginning of this rule that the penalty was too small. It's been adjusted a bit, but essentially the penalty is calculated per bed at the hospital level. So it's a price per bed. So what that means for a particular hospital is that it could basically range from $300 to $5,000 a day in terms of penalty, depending on the size and the number of beds the hospital has. So, you know, that depending on the hospital, like that might not actually be that huge into their margin, but depends. It has some teeth. It depends who you ask if they say how much teeth it has, and there's not been that much enforcement yet. The federal government has started. A few hospitals in Georgia got some official enforcement. They've sent out about 350 letters of kind of warning letters to certain hospitals around that compliance, and then certain states have started to use their authority to kind of reinforce the federal government's compliance oversight. So as an example, in Colorado, their legislature passed a law that like ties compliance with the hospital rule to actions that the hospital can take around collecting debt from a patient. So they basically said, you have to stop all your debt collection until you comply with the hospital price transparency rule, kind of a creative approach. And some other state legislatures have just started to take action around issuing their own kind of enforcement to reinforce the federal level.
Okay, that's great. That's interesting. Well, I'm realizing that we are essentially out of time. So let me say thank you, Avital. Thank you, Kevin, and Amy as well, who I know was supportive of the presentation. So thank you to all of you, and we look forward to seeing everybody at next week's Igniter session. And thank you all for joining us. Have a nice rest of your day.
Thank you.
Yeah.